So I would like to now start with our red blood cell pathology portion of our lecture. I'm going to start with polycythemia. Polycythemia means an elevated hematocrit. This means an increase in the number of erythrocytes in the blood. How does polycythemia affect blood viscosity and thus affect blood flow? Well, if the blood viscosity is caused by the red blood cell count, and I'll remind you that is the most numerous cell type in the body, it is most certainly the most numerous cell type for the formed elements in your blood. If red blood cell count goes up, so would your blood viscosity. I'll remind you that blood is 5 times as viscous as water. We oftentimes say blood is thicker than water. How would that affect blood flow? Blood flow is a volume per time. So if a blood sample is more viscous, thicker, it might seep through the vasculature much like molasses. And if blood is thicker, it would not go through the vasculature in the same amount of time. So having a thicker blood would reduce your blood flow rate. Again, blood flow rate is a volume of blood, milliliters per unit time. I would like to cover 3 pathophysiological categories of polycythemia. I have numbered them here 1 through 3. This does not indicate the order of their pathology. One is not more severe than the other. Relative polycythemia really refers to a patient that is dehydrated. The red blood cell count is normal. The mass of the red blood cell is fine, but it's the plasma volume that is decreased. This, of course, would be transient. Again, this represents a patient that is dehydrated. If a patient is dehydrated, and we think how we calculate hematocrit, hematocrit is determined through a division problem. We divide the red blood cell column by the whole blood column volume height in millimeters. If this is reduced because we have the whole blood column is reduced because the plasma compartment is reduced, then the whole blood column would be bigger in the numerator compared to the denominator, and this would lead to a higher level of the hematocrit. This would suggest polycythemia. All we have to do is rehydrate the patient. But what if dehydration does not provoke conversation about what could be wrong with the patient? What if this is a very well hydrated patient? Well, then we go to the other disorders where polycythemia is a problem. Again, we're talking about increased number of erythrocytes in the blood. Polycythemia vera is also called primary polycythemia. It is a problem with the stem cell, the hemocytoblast. Oftentimes, this is a problem with a genetic issue, a genetic mutation, or a cancer issue. The hemocytoblast is replicating and dividing inappropriately. It is not obeying negative feedback procedure through the erythropoietin kidney procedure that I told you about earlier. We would see an elevated hematocrit. We would also see an elevated white blood cell and platelet count. So total blood volume would go up. not just the red blood cell count. Erythropoietin levels would be decreased, lower below normal. The treatment for this, aside from treating the cancer, if that's what it was caused by, would be to bloodlet the patient and add isotonic saline solution to dilute the blood. Secondary polycythemia, shown here as my third category, is most oftentimes seen as an adaptive response. It's an adaptive response. In this case, the kidneys have detected a reduced oxygen carrying capacity. They detect reduced oxygen levels in the blood. So reduced oxygen levels in the blood would be hypoxemia. For the kidneys, this would also translate to tissue hypoxia, reduced oxygen content in the kidneys, a specific tissue. The EPO levels in this case we would predict would be increased. The kidneys releasing more EPO would drive, hopefully, more cell division from the hemocytoblast. Don't forget that the liver can also release erythropoietin. So if the liver is also trying to adjust, we might see that EPO level might be decreased from the kidney, but increased from the liver, and overall in the body, this might be a normal EPO level that we detect when we draw blood from the patient. When might be secondary polycythemia viewed as a normal adaptive response? From a person going to high altitudes, a person who is pregnant. If a person is pregnant, then they have a fetus that is using the oxygen from their blood, and their kidneys would detect this reduced oxygen level in the blood and would provoke the kidneys to release more erythropoietin. However, secondary polycythemia could be a diseased state. There could be inappropriate increase in EPO production, maybe because there are respiratory or cardiac issues. So secondary polycythemia, by large part, is seen as an adaptive response. But it could be because of a diseased response. Clearly, many tests would have to be done beyond the traditional hematocrit test. Now I'm going to go on to the next set of red blood cell disorders. I'm going to talk about anemias. The strictest definition of anemia is a reduced oxygen carrying capacity. How can a person have a reduced oxygen carrying capacity? There are many ways. They can have fewer red blood cells. They can have red blood cells that are inappropriately made, where the synthesis fell short. Earlier segments in this lecture, I told you about the ingredients needed to make a healthy batch of red blood cells. Maybe we didn't have adequate iron. Maybe there wasn't adequate protein synthesis. A myriad of reasons could be at the root cause for anemia. Maybe it is a blood stem cell disorder. But the basic definition of anemia is a reduced oxygen carrying capacity. Earlier, I told you that oxygen can be transported in blood in two ways, either bound to the iron within the heme group or dissolved in plasma. How much oxygen can be transported bound to iron depends on how well your red blood cells are formed or filled with hemoglobin. This is the lab value we measure all the time, called hemoglobin grams %. The other way we transport oxygen is dissolved in plasma. How much oxygen is dissolved in plasma depends on our ability to breathe oxygen into our lungs. We will discuss this in a much later conversation. Shown here on this slide are the two strictest ways a person can be anemic. Again, anemia, reduced oxygen carrying capacity. It is a blood cell synthesis versus blood cell loss removal equation. You can have a deficiency in red blood cells because you either cannot make them well or because you remove them too quickly. Synthesis and removal should balance each other. To the right of your screen, I'm showing you deficient red blood cell production. You can't make your red blood cells well. There's a problem with overall releasing them from the bone marrow. These problems include iron deficiency, aplastic anemia, and megaloblastic anemia. To the left of your screen, I'm showing you that you could have blood cell loss. You can have blood cell loss because you're bleeding. That means hemorrhagic issues. Are you bleeding because you have a chronic hemorrhage? Maybe you have an ulcer in your stomach. Maybe you are a female that has a heavy menstrual flow. Or do you have an acute hemorrhagic issue? Did the great white shark bite off your forearm? You lived to tell the tale, but you had significant blood loss, but acutely, meaning short term, significant when it happened, but short term. Blood loss can also occur because your red blood cells are being removed from circulation too quickly. Why might they be removed from circulation too quickly? Either you have inherited reasons why. Your red blood cells maybe have an irregular shape or size. They emerge from the bone marrow relatively decently okay, but over time they are removed. They are removed through a hemolytic process using macrophages. Another way we can have red blood cells removed by macrophages is because of an acquired reason. Maybe you were given a red blood cell transfusion that was not compatible, and your macrophages deemed those new red blood cells to be worthy of an antigenic response. If you're exposed to drugs, certain drugs, venoms, say from hemolytic rattlesnake venom, those can also be reasons why your red blood cells could be attacked and removed from circulation. Please pay attention to the colors that I have on this slide. In the future, any slide that has an orange title will refer to a hemolytic blood loss. Any title that has this pink/reddish color, salmon color, will refer to hemolytic loss that is inherited Any blood loss that is in a dark blue or almost light purple color will refer to a hemorrhagic loss. And anything that is referred to as a deficient red blood cell production will be in a light blue title. I will start with the light blue title. Let's start with iron deficiency. This is a type of deficient red blood cell production. At its simplest, basic definition, iron deficiency means you are not able to intake iron from your diet. Maybe you aren't eating enough, ingesting enough, or you're not able to absorb enough. Maybe you're not able to absorb enough given your recent demands. Maybe you are pregnant. Remember, when you're pregnant, you are eating for the baby. Iron deficiency can also be an issue if you have chronic blood loss, and I will get to that in just a moment. Earlier, I told you about iron metabolism. Iron metabolism means much more than eating nutrients, food sources that give you enough iron. This is beyond eating red meat or vegetables that give you enough iron. We're also talking about transport and storage of iron. If a person has iron deficiency anemia, their cells will be microcytic. Their MCV will be reduced. I'm writing this down now. They also will not have enough mass to their hemoglobin within the red blood cells. So their MCH will also be reduced. I'll remind you that MCH stands for mean corpuscular hemoglobin. Mean corpuscular hemoglobin should be, under normal levels, 32 picograms. Their mean corpuscular hemoglobin concentration would also be down. I'll remind you that mean corpuscular hemoglobin should be 34%. When we talk about MCV and MCH and MCHC together, we're really talking about a mass to volume ratio. MCHC is a division, a math problem, where we divide MCH divided by MCV. MCH is a mass, picograms. MCV is in units of volume, cubic microliters, cubic microns, for example. In this disease category of iron deficiency, all three are down. When all three are down, a student typically thinks that MCHC wouldn't be changed. This would only be true if MCH and MCV reduced proportionally. How can I explain this? Let's say you get a 50% on your exam. I'm writing this up at the top. You got 50 questions right out of 100. You got a 50%. Let's say that I tell the class, hey, turns out that some of those questions weren't fair. So I'm grading your score out of 50 instead of 100. And let's say those 50 questions that I'm focusing on you got correct. You would get a 50 out of 50. In which case your percentage would now be 100%. You would be a happy person. But let's say that the 50 questions you got correct were the 50 that I were throwing out, that I said wasn't fair. And let's say now you got a 0 out of 50. You would have a 0%, and you would not be very happy with that score. MCHC is a percentage. It is a mass divided by volume. You can think of this as the number of questions you got correct divided by the number of questions that you had available to you. In iron deficiency, all three values go down. MCV goes down, MCH goes down, and MCHC. They are not directly proportional. They are not proportional at all. The reason why MCHC also goes down is because the numerator, the MCH, goes down proportionally more. That's like me saying, hey, originally you got a 50 out of 100, but the 50 questions I'm throwing out, when I throw those 50 questions out, you actually got, let's say, a 15 out of 50. You now would have a 30% for this exam score. Let me say it again a different way. In iron deficiency, the red blood cells are so poorly made, they are so small, reduced in mass, that when they're divided by their volume, their overall percentage, their MCHC, which is a mass to volume ratio, is also reduced. When else can we see a reduction in red blood cell synthesis? Again, we're in the light blue category. This can happen in aplastic anemia. When a patient has aplastic anemia that is primary, we oftentimes refer to this as idiopathic, meaning the physician doesn't really know why the person isn't having appropriate red blood cell synthesis. When it's primary or idiopathic aplastic anemia, it is bone marrow failure. Maybe there's a genetic disorder with a hemocytoblast. Maybe there is some other causative agent that we have yet to be able to identify. Well, I shouldn't say cancer, because then cancer we would be able to identify. Well, idiopathic simply means, let me say it again, we cannot identify a specific reason why the hemocytoblast cell is failing. In secondary aplastic anemia, we can identify a reason why the hemocytoblast cell is failing. Maybe it is cancer. This is what I mean by malignancy. Maybe the person has been exposed to a significant amount of radiation. Maybe they've been exposed to chemicals like benzene or antibiotics, which has caused the person to have an adverse reaction. When a person has an adverse reaction to a drug that most people do not have an adverse reaction to, we say this is an idiosyncratic reaction. An idiosyncratic reaction to antibiotics or chemotherapy would be a reason why a person could have aplastic anemia. So let me say this again. Primary or idiopathic aplastic anemia, we cannot for sure identify a reason why the hemocytoblast is failing. It just is. Maybe it is a genetic disorder that we have not detected yet. Secondary aplastic anemia means we can identify why the hemocytoblast is failing. Again, adverse reactions to drugs, antibiotics, chemotherapy, exposure to radiation, immune suppression of the stem cell, maybe the person's on cortisol, malignancy. A kissing cousin to aplastic anemia is a condition called hyperproliferative anemia. This stems from reduced erythropoietin. Remember, most of our erythropoietin comes from our kidneys. If the kidneys are failing, or if there is a disease that goes after the kidneys, or if there is an endocrine disorder like hypothyroidism or hypopituitarism, this could explain why the kidneys are failing. Hypothyroidism, I'll remind you from your endocrine disorders, the thyroid hormone is permissive for all other hormones. How can a reduced anterior pituitary, hypopituitarism, be a causative agent for hypoproliferative aplastic anemia? I'll remind you the anterior pituitary releases TSH, thyroid stimulating hormone. If that is decreased, then the follicular cells in the thyroid would not produce enough thyroid hormone, and that in turn would reduce the amount of erythropoietin released by the kidney cells. Another category that falls into deficiency of red blood cell synthesis would be megaloblastic anemias. Megaloblastic anemias are a deficiency in either folic acid or vitamin B12. Both folic acid and vitamin B12 are coenzymes in the synthesis of thymidine. Thymidine is a nucleotide. It is important for DNA synthesis. I'll remind you that in DNA synthesis, thymidine is base paired to adenine. When we are synthesizing DNA during the S phase, during the cell cycle, for every A, you need a thymidine. If for some reason thymidine levels are low, then DNA synthesis is going to be halted. And instead, the cell, if it can, will focus on RNA production. You see, DNA is used for two reasons. Either it's used as a copy for DNA replication during mitosis, or it is used for a copy for transcript synthesis. If you remember, when we make RNA, we do not need thymidine. We need uracil. Uracil replaces thymidine. So if thymidine is rate limited, then the cell will focus on RNA production. The cells, if we're talking about hemocytoblast cells that are responsible for making red blood cells, these precursor red blood cells will become large, megaloblastic. They can even be irregularly shaped. They can also have fragile membranes. They could be removed sooner. So megaloblastic anemias could be a disease state where it crosses between not able to produce enough red blood cells, but also having them removed too soon. Turns out with megaloblastic anemia, the primary issue is that you are not able to make them correctly. The picture in this slide is showing you megaloblastic red blood cells. How do I know they're large? They are almost the size of a lymphocyte. Lymphocytes are white blood cells, and they are much larger than red blood cells. The red blood cells shown in this picture are clearly about the same size or even bigger than the lymphocyte that is shown here. If you don't remember what a lymphocyte looks like, it is the cell that has the very large purple nucleus in the middle. The red blood cells shown on this slide do not have a nucleus. They look like they have a hollow center, like a donut in this picture. And these red blood cells look to be about the same size or larger than the lymphocyte. These red blood cells have an increased MCV, an increased mean corpuscular volume. They also have an increased mean corpuscular hemoglobin. They have more hemoglobin that can fit into the cell. Their MCHC, a ratio between mass and volume, is the same. They might have a normal MCHC. If you get a 50 out of 100 on test, you have a 50%. If you get a 25 out of 50, you also have a 50%. MCHC is a percentage. MCV would represent the size of your test. Is it out of 100? Is it out of 50? MCH, mean corpuscular hemoglobin, the amount of hemoglobin in a specific red blood cell, would represent the score on an individual test. Again, if you get a 50 out of 100 or a 25 out of 50, you still would have a 50%. I'm going to write this down again. MCHC, a percentage, is determined between MCH, the mass of hemoglobin, divided by the volume of a red blood cell. Maybe you don't know what a coenzyme is. I said on the previous slide that vitamin B12 and folic acids are coenzymes. What is a coenzyme? A coenzyme is something that will help an enzyme do its job better. Shown here in dark blue is an enzyme, and in light blue we see a coenzyme. The empty space shown here is showing you where the substrate would bind. In some enzymes, if they don't have their coenzyme bound, if it is vacant, then we say the enzyme is an apoenzyme, and it doesn't have the proper conformation to function, meaning its binding site might not be available to the substrate. But if the coenzyme binds to the apoenzyme, It will then make a conformation change to the enzyme where now the substrate can bind, I'll circle it in red, the substrate can bind to the binding site. And now the enzyme can convert the substrate into a product. So a coenzyme is something that would help an enzyme do its job better. I like to think of my PowerPoint slides, my projection screen, everything that I use in a lecture room as my coenzymes. They let me do my job a little bit easier. I don't have to keep talking and drawing on the chalkboard or whiteboard. My computer, my projection screen, my PowerPoint slides are all coenzymes. They help me do my job, which is to facilitate your learning a little bit better. In megaloblastic anemias, a person can become deficient in folic acid or vitamin B12 in a myriad of ways. Folic acid, we ingest that when we eat a healthy amount of leafy green veggies. Vitamin B12, we ingest that when we eat a healthy variety of meat, dairy, and eggs. Both of these coenzymes are stored in the liver. Folic acid is stored in the liver for about 6 to 9 months, meaning if you didn't eat any green veggies, your red blood cell synthesis should be okay for about 6 to 9 months. For vitamin B12, your liver can store a supply of that for about 3 to 5 years. There is a greater demand for both of these coenzymes when a woman is pregnant. Why? Because both of these coenzymes are necessary for thymidine synthesis. The enzyme for thymidine synthesis requires these coenzymes. Without a good concentration of these coenzymes, we cannot make enough thymidine. Without enough thymidine, we cannot replicate our DNA. And that means cells switch over to gene expression, using the DNA as a template for a transcript. When this happens, you would have fewer red blood cells, fewer proerythroblasts, for example. And because you have fewer of them and they are focusing on gene expression, they would get bigger. They would become megaloblastic. How can a person have a reduced folic acid storage supply and vitamin B12? Maybe they're not having adequate nutrition. Maybe they have sprue, inadequate ability to absorb their nutrients. Maybe they are on medication like anti-cancer drugs that interfere with absorption. Maybe they are not having a good diet in a different way. Maybe they have a problem with their liver function, alcoholism, cirrhosis of the liver. In the case of vitamin B12, we can also see that a person can have a lack of vitamin B12 if they have a gastrectomy or gastric atrophy. And the reason why this could be a problem is that we have cells, parietal cells, in the gastric mucosa. One of their jobs is to release hydrochloric acid, but also intrinsic factor, which is a glycoprotein. An intrinsic factor, when it's released in the stomach by the parietal cells, it targets cells in the ileum whose job it is to absorb vitamin B12. Some things can inhibit parietal cells from releasing intrinsic factor, and alcohol is one of those things. So a person who is an alcoholic, not only will they have poor nutrition if they are really severe, but they also, with their intake of alcohol, can inhibit their parietal cells from releasing intrinsic factor, and in turn reduce the ability of their small intestinal cells, their iliac cells, for example, from absorbing the vitamin B12. My last slide for this segment of my lecture is switching to the dark blue, almost purple section, and this is now referring to blood loss, hemorrhagic blood loss. So please note that this is no longer light blue, but a dark blue, light purple. I'm now in the blood loss compartment. You could have anemia because your red blood cells are normal. They are normal size, normal shape. They are filled with the adequate amount of hemoglobin. So everything is normal. Normocytic, normochromic. They have normal everything. Normal mean corpuscular volume, normal mean corpuscular hemoglobin, normal mean corpuscular hemoglobin concentration. When it's acute hemorrhagic anemia, it really means that you have hypovolemia. You have reduced blood volume. This can lead to shock and death very readily. But let's say you have a slow bleed. Let's say you have a very strong menstrual cycle if you're female, or maybe you have a bleeding ulcer. When you have a chronic hemorrhage, this no longer is in the category for blood loss. When you have a chronic blood loss, it actually tips into the category of inappropriate red blood cell synthesis. The reason why it's a problem now with red blood cell synthesis is because your small intestine cannot keep up with the iron absorption. The demand for the iron in your red blood cell synthesis is too great for your small intestine to keep up with. So it leads to an iron deficiency anemia, which means with chronic hemorrhage, it turns into the light blue category. You have a problem with making, not a problem now with losing too much. Do you see the irony? And not to be ironic and kind of snarky, but irony and iron is the problem. Funny, funny. So the red blood cells will be microcytic, too small, hypochromic. They're not being adequately made in size and not adequately filled with hemoglobin because you don't have the adequate iron from your diet or absorbing it from your diet to keep up with this demand. Now, in the news, especially recently, there is quite a bit of conversation about synthetic blood, plastic blood, blood that possibly soldiers could take when they're out in the field. And let's say there's a wounded soldier and the medic gets to the soldier and the soldier needs a blood transfusion, but let's say now's not the time to actually give a blood transfusion. How do you transport that in the field, especially if you're in the desert somewhere? How do you do that? How do you transport that? Well, there's actually quite a bit of focus on this plastic blood where you can dehydrate it, desiccate it, shown here in the little plastic dish, and then all you have to do is add water, and then you can resolubilize that plastic blood. And it's not perfect, but it actually can replace the blood volume. It doesn't require refrigeration. And as you will learn as we go through the semester, a lot of times it's not just so much delivering oxygen, but blood pressure. So having this plastic blood that we can resolubilize, add water to, give to a soldier that might be wounded, increase their blood volume, increase their blood pressure, and restore blood flow might buy them some time where we can transport them to a hospital where we can get them real blood. All right, so that ends this next segment, or this current segment. The next segment will be my last segment, where I'm going through the rest of the anemias, where I'm going through the different categories of anemias.